بسم الله الرحمن الرحيم. زملائي الأعزاء، أبنائي بناتي من أطباء الأسنان في الجمهورية، ولي أبناء وبنات كمان في الدول العربية الشقيقة يعني. برحب بيكم كلكم وكل سنة وانتم طيبين. فرصة جميلة جدا إن احنا نتقابل في الويبينار الثالث، وجميل جدا إن احنا نتقابل النهاردة مع بروفيسور كبير الحقيقة في البيدياتريك دنسري، بروفيسور نخيل مروة، واحد من أشهر وأمهر البروفيسورز في طب أسنان الأطفال. له نشاطات أكاديمية وكلينيكية يشار إليها بالبنان حقيقة وتدعو للفخر. حد من الناس الجميلة اللي تحبوا تسمعوا لها، وهيتكلم في موضوع مهم هو البالب ثيرابي in primary teeth. Professor Marwa has an astonishing CV actually. It needs a decade to be fully read. Professor Nikhil Marwa is a professor and head of Department of Pediatric Dentistry, Mahatma Gandhi Dental College, Mahatma Gandhi University of Medical Science and Technology, Jaipur, India. Professor Marwa is an editor-in-chief of International Journal of Clinical Pediatric Dentistry, Vice President, Indian Society of Pedodontics and Preventive Dentistry, Chairman and International Collaboration Committee of ISPPD 2020, National Executive Member, Indian Society of Pedodontics and Preventive Dentistry, Associate Editor of Journal of MGUMST, Editorial Board Member of World Journal of Dentistry, Review Board of many international and national journals, editor of the Journal of Indian Dental Association, postgraduate and undergraduate examiner panel of many universities and dental colleges in India, included as the CI Inspector by Dental Council of India, member of Dental Council of India, Syllabus Revision Committee for Pediatric Dentistry, and member of Dental Council of India Webinar Committee for Pediatric Dentistry. Let us all welcome Professor Marwa. You are most welcomed in this webinar, and we are actually waiting for this webinar, me and my colleagues who are interested in pediatric dentistry, who are, struggling in doing pulp therapy in primary dentition. Too many of our colleagues are struggling in this point, so they are very excited to hear you today. Maybe you are going to solve some of their problems they are facing maybe day by day. So you are welcome on board.
Thanks a lot.
You are welcome, Doctor. You can start your, if you want to say anything in the beginning, and then you can start your lecture.
Okay. Yes. I would actually, I am really grateful to you for considering me for this particular webinar. And it's been a long time since I've done it. I had taken a sabbatical for a few months because of my son's exam. And in fact, you were the first ones I answered after some time. Yeah. So it's like a restart from Egypt. So I am really thankful to you, Professor Avir, Dr. Hamza, and the Egyptian Dental Syndicate for considering me, able enough to deliver this particular talk to all of you. And without much ado, I would actually start the lecture now. And the lecture today would focus on the pulp therapy in primary teeth and the common problems which all of us face during the various procedures which we undertake in pulp therapy. And we would be having a question answer session at the end. Is that how it goes, or?
Yes, exactly. It's very, very good. Yes, to make the questions at the end of the session.
Okay. So should I start my screen sharing? And if you could tell me if it's on, can you see the slideshow now?
Yes, doctor, everything is okay.
Yes, yeah. We can see.
Perfect. Do you want me to break for the prayer or something? Or is it okay if I continue? Hello, am I audible?
Yes, doctor. Yes, everything is okay. You can
Okay,
start.
perfect, perfect. Okay, so a very big good evening and a hello to everybody in Egypt from all of us in India. I am sure you are going to enjoy this good evening session with a hot cup of coffee, and I'm sure we all will have a very interactive and a fun session where we would learn something, and probably I might also learn a few things. So this is me. I am Dr. Nikhil Marwa, and as introduced by Professor Abir already, I am in Mahatma Gandhi Dental College and Hospital, which is a unit of Mahatma Gandhi University of Medical Sciences and Technology in India. So this is our small department where we actually practice exclusive pediatric dentistry and work most of the time during the day. So this is our setup, which I always like to show in the beginning because this is who we actually are, what we actually do. Without much ado, I will now focus on pulp therapy in primary dentition or pediatric pulp therapy. Most of the times, whenever we are thinking of pulp therapy in children's teeth, milk teeth, or primary teeth, whatever they may be called by various names, by various dentists, but the whole point is that we are not just caring or thinking about baby teeth. It's an easy answer to say that baby teeth will go off and we can actually extract them and we do not have to go through with the whole effort of pulp therapy. But imagine the implications it would have. So, baby teeth are not actually just baby teeth. A wonderful article written by my friend Sharat in one of the leading Indian newspapers. This is a long time back, but the whole idea is to tell you that baby teeth are not just baby teeth. You need pulp therapy in pediatric dentition so that you can help the child maintain a good oral health. A good dental health is an ideal scenario for a good oral health or a good general health because you need to prevent so many things. You need to prevent nasal drifts, you need to aid in migration, if there is any speech problem, if there is maybe early loss of the anteriors due to caries process, imagine the amount of speech problems and the aesthetic problems the child would actually face. Maybe even it may even lead to some aberrant tongue habits. And to top of all this, the psychological trauma, or due to the peers, or due to friends, or due to school, the psychological trauma which the child undergoes because of these carious teeth is immense. Or even if they're extracted, the void spaces which are created, or the edentulous spaces which are created, would create an equally big psychological trauma. So, the whole essence or the whole point of maintaining the pulp therapy in primary teeth is to focus on these small scenarios which will help us not only prevent the caries, but also if we get a carious tooth, we need to save it and not just extract it. So once we come to pulp therapy proper, I would, actually divide it into vital pulp therapy and non-vital pulp therapy. When we are talking about vital pulp therapy, my main focus would go towards the pulp cappings and the pulpotomy. Whereas when we are indicating non-vital pulp therapy, it would be ideally a complete pulpal treatment. So if you start with indirect pulp capping, or even probably if you want me to classify, I could tell you that more than 50% of the cases which report to a pediatric dentistry OPD would actually be solved by indirect pulp capping if done properly and if done in correct time. And this is one of the most successful, most ideal treatment wherein we preserve the vitality of the pulp and actually save the tooth in actuality. And maybe probably rehabilitate it with a zirconia crown or an stainless steel crown. That is totally your choice. Or somebody may even say Figaro crowns. So what type of crowns you want to use is again totally your choice. But the indirect pulp capping, when a patient comes to you with absolutely no history of pain, and this is most of the time diagnosed as a proximal lesion, very much approaching the pulp, the ideal treatment or the golden rule for success of this particular thing is application of your calcium hydroxide. If you are using a dical type of a calcium hydroxide, always mix it in the cavity. And if you are using something like a binary LC or a light cure calcium hydroxide, you can go ahead and do the normal way. But the whole idea is to remove the infected pulp, the soft carious dentine that has to be removed. The soft carious dentine or the soft caries process has to be removed. The infected caries has to be removed, and the affected dentine has to be left behind. The affected dentine will in fact help in rehabilitation and prevention of pulpal exposures. So the golden rule in indirect pulp capping would always be a clear-cut identification. As you can see, even in the radiograph which I am showing you here, you can see a clear line of dentine. When you see a clear line of dentine between your carious lesion and somewhere here, if you ask me, and here we go. Yeah, somewhere. So a clear zone of dentine, a layer of dentine between your carious process and your pulp is an ideal indication of a pulp capping treatment. When you move on from this particular step to the next one, that becomes a pulpotomy. Now, most of the times we do pulpotomy when a patient comes to us and a mechanical exposure happens. That is the ideal indication of a pulpotomy. That whenever we are doing a caries excavation and we end up exposing the pulp. Now, the ideal indication that a tooth would be receptive enough to pulpotomy is that the bleeding must be controlled. Once you enter the pulp chamber, the first spot of bleeding should be bright red, and once you open the coronal pulp chamber and you clean the entire area, make sure that there is no bleeding just by irrigation or by a regular pressure pack. If you can control the bleeding and you can see the pulp stumps, but you see the redness, but there is no frank bleeding, that means it's an ideal scenario for a pulpotomy treatment. Now, such treatment can always go ahead and place your crowns just to protect whatever you have done. The ideal scenario or the golden scenario, golden rule for success in cases of pulpotomy would be your case selection. In the sense, if it's a case where a patient is already giving a symptom of pain, then it is not an ideal case for pulpotomy. If, of course, you see some kind of a periapical changes in the radiograph, then again, it's not an ideal case for pulpotomy. But if the patient comes to you with no history of pain, again with no obvious radiographic periapical involvements, this becomes an ideal scenario for pulpotomy. And once you open the coronal pulp area and you evaluate that the bleeding can be controlled, please go ahead and do pulpotomy with whatever choice of medicament you want, because there are innumerable choices of material when we talk about pulpotomy. We have the conventional devitalization pulpotomy, where we use formocrosol, one of the most widely used materials in India. Most of the European countries have, although, shown concerns for this. However, it is still being used in some places. The next one would be your preservation, which we normally use glutaraldehyde or ferric sulfate. Again, a very commonly used pulpotomy material. Or we could go for a regeneration using bone morphogenic protein or maybe some kind of a new material. Now, you would be surprised to know that pulpotomy is the material in which maximum research has been done with respect to the material placement, because right from your aloe veras to probably your MTA, bone morphogenic proteins. People have used PRP. They have used Manuka honey. People have used uh, all kind of herbal medicaments. And the best part is most of them work. And the reason is not that they actually work, but the reason is your case selection. If your case selection is correct, then whichever material you are using for pulpotomy is most of the times going to be successful. Now, that success may vary from maybe 80 to 90% between different materials, but most of the time, most of the materials would actually work. Now, in the current scenario, if you ask me that which is my material of choice for pulpotomy, I think I would go with biodentine. The plain simple reason for this is it doesn't stain the tooth, it sets much faster, its consistency for handling is much better, and the best part, it is much, much more cost effective to MTA. So you have a material now which is a kind of a biomimetic material or a regenerative kind of a material, yet it is cost efficient. So all these things point to a ideal combination of biodentine being the material of choice now for pulpotomy procedures. Now, if you come to the pulpectomy zone of it, now as we decided or as we saw earlier, that if the patient comes to you with absolutely no symptoms and you see a definitive dentine layer, you go for an IPC. If you have done a mechanical exposure, you go for a pulpotomy. Now, if the patient comes to you with absolutely normal symptoms, by what normal symptoms I mean, he does have pain while chewing, maybe some pain, but when you take a radiograph, he shows absolutely no periapical pathology. This is an ideal indicant for single sitting pulpectomy. Please mark my words. When a patient shows symptom but there are no periapical changes, it's an ideal indication for single sitting pulpectomy. Wherever you get some periapical issues and periapical changes, then it is best to go for a multiple sitting pulpectomy because you are giving the time for the teeth to repair. Now, if we talk about pulpectomy, which is one of the most common procedure done in case of primary dentition, this is just a pictographical representation of various things what you're going to do or various things what we're going to discuss. We are going to discuss the access opening part, the biomechanical preparation, the obturation, and all these techniques would be discussed in general, or an overview of entire thing would be provided. Now, the first part, which is the most critical part, is the removal of pulp. Now, why I say this is the most critical part is because if we do not get the pulp out in a toto format or probably a single entity, then it is going to break into shreds. And removal of those shreds in primary dentition is going to be really cumbersome. So the ideal thing to do here would be to use a barb broach and remove your pulp. The technique of removal of pulp is very, very simple and very, very convenient. You use your barb broach, you move it along the walls of the red, along the pulpal component, and then shift to the center and then rotate your barb broach. Once you give a complete rotation movement, and this is the time you pull the barb broach out for complete removal of the pulp. Now, if some of us they want to be over enthusiastic and they put the barb broach right in the middle of radicular area, then it is going to damage the pulp or break the pulp, and it will be difficult to remove it later on. It will not come out in toto. So the ideal scenario would be move it along the walls, then get it on the center and rotate and then pluck it out. Now, this is a very controversial topic in pediatric dentistry. Now, why I say this is a controversial topic is because there are a certain, schools of thought or a certain set of people who say that the diagnostic radiograph is not required. And when we have the visual comparisons, we have the radiographic comparisons with the preoperative, and of course we have our tactile sensation. They are good enough to know working length. Whereas there are other schools of thought which say that no, diagnostic radiograph is an absolute necessity. Now, I don't know which side of the fence you want to sit on, but I am of the opinion that a diagnostic file radiograph may not be an absolute necessity. Yes, if you have a doubt regarding the working length, if you do not have an maybe an apical closure, or if you have maybe an extra root canals, then probably I would suggest a diagnostic radiograph. Otherwise, I think you can do without the radiographic exposures. However, even if you are taking it, you are not doing anything wrong. As I said, this is just my opinion. Now, electronic apex socketers also offer an equal degree of accuracy when it comes to location in primary teeth. Earlier, most of the times, it was thought that electronic apex locators would be ineffective in primary dentition due to the open apex. However, that's not the case, and one of the articles recently, it was 2015, but a very good analysis which was done, and it was found that electronic apex locators offer an acceptable level of accuracy, and that's good enough for the accuracy which you need in a primary dentition. I especially like this quote because it is a very much true statement. What you remove from the root canals is much more important than what you put back. Why I'm saying this is because if you do a good biomechanical preparation, if you remove the entire infected radicular dentine and your walls are completely debrided of all the infected dentine, automatically whatever material you use for obturation, you are going to have a good result. But then, of course, the techniques for biomechanical preparation is equally important. The only difference in biomechanical preparation for primary dentition and permanent dentition is in primary dentition, it is more about cleaning and shaping the root canals rather than having any kind of a step back or step up kind of a preparation. So here it is more about just cleaning the entire walls in a regular movement so as to give a nice open kind of a preparation so that your material completely flows into the root canals. Now, depending on choice, you have your H files, your K files, your reamers, your rotary instruments, whatever you wish to use for your biomechanical preparation is absolutely your choice. Now, if you want to use K files, you would have to use watch winding and pulling action, whereas H files are laterally compressed onto one side of canal and then pulled. Now, ideally, if you ask me, I would want to work with H files in primary dentition because the whole point of doing biomechanical preparation in a primary dentition is to give a smooth finish of the walls. So this can be very effectively got with the help of H files or maybe your night flex files also, which have a greater good effect because they are much more flexible. If you talk about the canal sizing, that is absolutely your choice. There is no fixed rule, although we do say that your first file entry is the first one and you can go to triple the amount of file. But again, all these rules specifically cater to a certain set of teeth, and once you're doing in primary dentition, it's very much easy just to clean the teeth, thinking that you are going to give a clean lateral walls irrespective of what size you are using. Now, a very, very important or a very, very thoughtful question amongst each of you would be rotary versus manual instrumentation. And this is as good as calling it old school versus new school. So if you ask me that what do I do, I am a person who uses both. So somewhere I am linked with the old school, but also want to enjoy the new school. The reason for this is Bar was the first one when they used Niatide prototype files in primary teeth. And trust me, when initially the filing systems were started for primary dentition, we had a very, very difficult time. But the newer systems which have developed are so foolproof and so efficient that you even forget that you are actually using a rotary dentition. Now, there are innumerable number of articles. If you see all these articles, and you can just go through them, you can search Google for them. There are innumerable numbers of article which you know try to see you or try to classify between your instrumentation times or your basically compare your rotary filing system to your hand filing system. All of them have varied efficiency, but two points which are common for all the articles are that it's much more efficient and much less time consuming. So you have a number of pediatric rotary file systems. I am sure there are at least 10 to 15 which are there, and internationally also there would be many more. These are the three which are currently used in India. So I, I am actually just depicting them. It's Prime Pedo, Pro FBB file, and Kido S file. So there would be innumerable number systems, and each of these file systems have upgraded themselves from multiple file systems to single file system. I am not sure how many of you did attend my last workshop, which I had in Alexandria for rotary file systems. And now, with the invent of the newer file system, it's become very, very easy. Whereas we have one particular file for the anterior segment and one for the posterior segment. So we don't have to worry about the finishing files, the initiating files, the starter files. So it is a lot less complicated to use these files now. Now, rotary obviously has its advantages. There's improving clinical efficiency, cleaning efficiency, consumption of less time, more comfortable for the patient, less apical extrusion of the debris because you are doing it in a pulling action or a up and down movement and not pushing it. And of course, better filling of obturating materials. Once you have a better uh, BMP, you are automatically going to have a better obturation. Now, two things what it definitely does is absolutely saves time and saves your back, saves your tiredness. And I think these are the most important virtues of today's dentistry because whatever you do, you are ultimately doing to save time. We had a 40-second cure machine, then we've come to 4 seconds cure machine. We have also single second cure machines. The whole point of this is because you want to save time and save your energy, which rotary instrumentation would definitely help you do. However, there is a pitfall to everything, and if you ask me, the pitfall here for rotary instrumentation is that in case of hand instrumentation you have a tactile sensation. That tactile sensation is very helpful in managing the child, whereas in the rotary instrumentation, you would not have the tactile feel. Second, in case of open apices, it is much, much easier to have a hand instrumentation than a rotary instrumentation. Some of the simple guidelines which we want to use for rotary instrumentation is that you must use the correct files at correct speed and correct torque. Do not overuse the file. This is the biggest drawback which we all have. We try to overuse our files and then ultimately we end up breaking the files in the canal and blame that the rotary system is not good enough. So please make sure that you don't overuse your file. Another very important point is always create a glide path. Now, in case of hand instrumentation, you may not actually need to do so, but in your rotary instrumentation, you would have to create a glide path. Then only your file would go in smoothly. Always remember, do not start and stop in the canal. You have to start it and then take it, because if you start and stop in the canal, you are increasing the chances of breakage. Always remember these certain rules which are going to help you in rotary endodontics. Straight line accesses, a glide path, and cornel flaring with rotary taper instrument. Now, once you do all these things, if once you have a straight line access and you have a glide path, your rotary instrumentation is going to be a cakewalk. So the most important aspect of rotary instrumentation is a glide path. Otherwise, you very well know what I am depicting in these photos. What will happen if you do not have the glide path? You will end up perforating the tooth in some or the other canal. That's a definite yes. Another important component, yet often neglected component, is endodontic irrigation. We always think that endodontic irrigation is not one of the important aspects of primary dentition. However, I would want to tell you that the endodontic irrigation forms a very important aspect. Now you have various irrigating solutions available with you. You have your chlorhexidine, you have your sodium hypochlorite, you have your maybe herbal mouthwashes. People even do with salines. You have ozonated oils which you have to use. But in the end, it all comes down to an effective irrigant. All irrigation solutions are good now, but you must irrigate effectively. Some of the simple ideal requirements for an ideal irrigant would be availability, ease of use, cost and convenience, of course, and no tooth discoloration, because you want it to available, you want it to be easy to use. Now, the only different advantage in sometimes sodium hypochlorite is when you are using it in children, all these things are good enough. However, the ease of use part is little bit tricky. So you have something like an ozonated oil also. So there you some have sometimes use of chlorhexidine also. So it totally depends on you what you want to use, but you should use at each and every step. And copious irrigation is very important for ideal root canal treatment. Now, there are multiple articles which you can find across uh, throughout the internet giving a complete review of all the root canal irrigants, even in primary teeth. And you must go through them or you must evaluate them if you have any doubts regarding the material which you are using. Another second important point in the particular aspect of irrigation is irrigation needles. What we often forget is if we try and irrigate with local anesthesia needles, you have a down end kind of a spray, which will damage the periapical areas to a greater effect. That is why endo irrigation needle, which is only dispersing on the sides or a much softer aspect, would be much important. And as summarized correctly by Nadar and Baumgartner, the complex root canal architecture of primary molars can be debrided by chemico-mechanical means only. So whether you use hand instruments or rotary instruments, it is absolutely fine. But you need to supplement that with a irrigating solution, and that is why it said chemo-mechanical means only. Now, once you've completed your biomechanical preparation, you of course come to your root canal obturating materials. Now, we all know these have been given since 1980s that there are innumerable number of materials which can be used, and they should be resolvable, antiseptic, radio opaque, easily inserted, non-inflammatory, and we all know this. But two things which strikingly come to our mind is one, they should be radio opaque because we want to see them on the radiograph. And second is they should be resorbable because when we are talking about primary teeth, we are talking about a material which resorbs along with the rate of resorption of the root and not more than or less than that. Now, the various materials or the most commonly used materials for obturating primary teeth are, of course, your calcium hydroxide. There are lots and lots of combinations which are available for calcium hydroxide, your seal pegs, calcicure, vitapex, and it entirely depends on the region you are, and calcium hydroxide would have a multiple combination. There is, of course, zinc original, which is an old school favorite, and you have some iodoform based pastes like walk-off paste, KRI paste, Mysto paste. They were all used in the old times, whereas now we are using Metapex and Endoflas a bit more. Now, why I am showing this particular thing is now there are innumerable number of studies, maybe thousands and thousands of studies, which have compared each and every material possible, each and every brand possible. But ultimately, they have singled out to a few selected materials only. But always remember that these selections or these choices were based on the resolvability and the clinical success rate. So, what they have concluded is, of course, zinc original old is gold. It is and it was one of the best materials for pulpectomy or one of the best obturating materials for pulpectomy. You have the Metapex, which is currently the best. I would say currently the best because it is again a new school material, yet it has broken ice with a lot of old school guys who want to use Metapex now, who were stuck on eugenol but now prefer Metapex because of its ease, its radio opacity, and its antibacterial properties. Another important material which has not caught the world of everyone, not caught the eye of everybody, is actually endoflass. So endoflass, I would mention it as a dark horse because it's an excellent material owing to its good setting capacity, its good manipulation time, as well as its perfect antibacterial properties and once it's in the root canal. So it is a very, very important material. Although the reason I am saying it's a dark horse is because not many people want to bet on it right now, and everybody wants to take the safe way out. So when to use which obturating material is, of course, a choice. Now, you may think that it is always best to go with your choice of obturating material. That's perfectly fine. You can do it in all the cases. But if zinc oxide original is your material of choice, then I would not advise it to be used in open apices teeth. The simple reason is if you extrude this material, it's going to one cause periapical irritation, second, it's going to set there and may even cause deflection of your tooth bud, and probably it may even cause a minor cystic lesion. So, in cases with open apices, Metapex is the best possible material. Even in closed apices, I would say Metapex is the best currently, as I told you. So the choice to use material is absolutely on you. However, my choice would be Metapex. Now, again, as we had innumerable number of materials which we can use, we also have innumerable number of techniques. Right from the 1960s, various techniques were developed by endodontic pressure syringe techniques, the mechanical syringe technique, the Jiffy tubes, incremental filling, lentillo spirals, paper points, amalgam pluggers, whatever you name it, you have it. Now, the advantage with Metapex is one more. You are actually not going to follow any of these techniques. You're just putting the material inside and gradually withdrawing your syringe. However, I would always recommend that you use a lentillospiral once you're used your Metapex. So the whole advantage of using lentillospiral is that its motion actually transports the material into the root canal. So even if you are having some voids, it is going to fill that. So amongst all of these techniques, if you ask me, my choice of technique would be a lentillospiral technique. Now, these are some of the cases which have been done by my friends, by me, by my friend, probably most of you would know Mukul, and Mukul has done some of these cases, and there is Milin. So these are all people. There's Ganesh. So these are all people who are contributing to their various cases, who are giving me the radiographs which I can use because they have done so beautifully, and I really hope I could do as good as them. So probably someday I would learn from them also, just like people learn from me. Now, one major question which comes to everybody's mind or comes to everybody's thoughts is that what happens once we get a cases with swelling or cases with periapical lesions. As you can see in these photographs, you have cases wherein there is a periapical lesion as well as there is a pus discharge or a sinus formation in the particular tooth in a second primary molar. Now, such cases are treated beautifully with triple antibiotic paste. You may have a ready-made triple antibiotic paste available, but sometimes in India we do not have this particular paste because somebody, I remember last time when I had come to Egypt, had shown me this particular product, but unfortunately it is not very freely available in India. So what we do is we have a combination of metronidazole, ciprofloxacin, and minocycline. We use these three combination and mix it with distilled water and make a paste, a slurry kind of a thing, and obturate this entire teeth with this slurry. Keep it there for 2 to 3 weeks, and we see brilliant results in 3 weeks. Just as you can see in this radiograph, in 3 weeks, there was absolutely no sinus, the mobility had reduced, and the periapical involvement, although radiographically was still visible, but clinically the patient was perfectly fine. So you could re-enter after 3 weeks and then go ahead and do your regular pulpectomy and close this teeth. So a teeth, a patient with swelling and sinus, which was initially indicated for extraction, is now actually saved by this particular treatment. Now, this is particularly of more interest when we have primary second molars infected and the first permanent molars have not erupted, because the distal tooth space maintainer, as we all know, is a very big difficulty to manage. So, for such cases, when you have such problems and you want to save a tooth, or maybe even try saving a tooth, treatment with triple antibiotic paste would be a very advisable or a very doable scenario. So if we just revisit what we have done from the entire aspect, now we had a pulp therapy where we had a vital pulp therapy in case of indirect pulp capping where we had a definitive layer. We had an exposure when you wanted to do a pulpotomy, mechanical exposure. We did with biodentine as the material of choice. We had a single sitting pulpectomy if the patient had symptoms but no periapical lesion or periapical changes. And we had a multiple sitting pulpectomy where you had any lesions and did with Metapex is the material of choice, used rotary, always made sure you had a glide path, obturated with Metapex, with using lentil spiral technique, and then you ended up with, in case you ended up with any swelling cases, you used your triple antibiotic paste to get your way around and actually save the tooth. It's very easy to say that you can extract and give a space maintainer. That's absolutely fine. And that's what we are taught as pediatric dentists. But what we also want to do is we want to save the natural dentition as much as we can. Now, with this small note, I hope I have not taken much time with all of you, and I hope I have finished in the time due allotted time. I think, Dr. Avi, Professor Avi, I think
Yes,
that's it.
yes,
Thank
yes,
you from my
exactly on
side.
time. Yes.
I hope
Thank
I
you
did
very
not
much.
bore you all.
No, no, no. We want to hear more if you have. No, it's exactly on time. Thank you very much. Uh,
Yeah.
I'm asking now to submit any questions from the attendees. But excuse me, may I ask you any news or any recent research on pulp mummification in cases of extremely uncooperative children that we
Yes.
cannot, some
What?
dentists cannot manage?
Yes. For such cases, we have to use something like depulpin. It's a pulp devitalizing paste which is readily available. And what
Mhm,
they must do is must access at least one dip in the pulpal chamber, and then they can place that medicament
mhm.
and seal for 24 hours. Once they would revisit the patient after 24 hours, the pulp would be completely non-vital.
And there is no completion for the regular endodontics after that. Just final
No,
restoration.
absolutely not.
No,
Yes.
because of
No,
the
we have to
uncooperation of the child.
we have to no no we have to do a pulpectomy after that. But the whole point is that a pulpectomy would be much it would be easier for do if we are dealing with a non-vital pulp rather than a vital
Oh,
pulp.
yes, I see. So what about Pulpotec in this regard?
Yes, that's the same. The pulpotec
This
is
is
a
the same.
revitalizing paste, which I was
Yeah.
talking about.
So used just temporarily until, relieving some of the symptoms and then completed by the regular or traditional
Pulpec. But
pulpectomy.
do not keep the pulpec in place for more than 24 hours. 24 hours is good enough for the pulp to become non-vital. You don't want to extend that beyond
Yeah.
that time.
Mm, mm. And if there is no ability, I think extraction as space maintainer if it is indicated.
Of course.
And this
But
extreme
uh,
uncooperation
but
because you
but I guess if you ask me, it's much easier to do a pulpec than to do an extraction because you can
so,
do a
so
pulpec without local anesthesia, but you cannot do an
yeah,
extraction without a local anesthesia.
yes, exactly. Yes.
So if the patient is uncooperative,
Okay.
I think the most dangerous procedure to do would be a local anesthesia.
Uh,
Not
dear
that much.
colleagues,
Just a second. Okay, Nashwa.
dear colleagues, if
Dr.
anyone have a
Nashwa,
question, if anyone have a question, please leave it in a question
chat
bar.
box.
Okay. Yes. There is a question. Okay. Um, we don't saying we don't need an anesthesia in second visit after desensitizing the pulp.
No, we do not.
Sure.
We do not. Once you desensitize the pulp, after 24 hours when you visit it, it's completely non-vital. And even if you
Mm,
feel there are some pulpal remnants in the radicular area, you can go for an intrapulpal anesthesia.
yes, yes. Also, a question until receiving another one from the attendees. Uh, what about the regarding the oldest gold of zinc oxide agenol? What about the slow or sometimes no resorption and the possibility of bad
Uh,
deflection of the successor? Why it is gold then?
as long as zinc usinol is in the root canals, all the studies have proven that its resorption rate is the best as compared to any other material. It resorbs at
Mm,
exactly the same rate as our roots. Metapex resorbs much
mm,
faster. Calcium hydroxide
sure.
resorbs even faster. So zinc
Mm,
cyclohexanol, if it's in the canals perfectly, that is why I say old is gold, because if it's perfectly in the canal, it will resolve with the tooth. That is the ideal
with the tooth.
scenario. Now,
Yeah,
yes, if
yeah,
it goes beyond apex, then only it can cause a periapical
yeah. This
lesion
is a
or maybe a trouble of
mm,
deflection of tooth. So as I said very clearly, if it's open apices and you have a fear that you might push the
Yes.
material out, for such cases, Metapex is the best.
Oh, yes. So the problem
Another
here
question.
comes from the extrusion of
Um,
the material beyond the apex.
Yes. Yes. If it's
okay,
not
there is another
extrusion,
question.
ZOE.
Yes. Okay, Dr. Nash. I see.
Role of pulpotech in pulpectomy. Pulpotomy, sorry.
Uh, See, role of pulpec in pulpotomy is very wrong because see, it's like you are doing something like a two-visit devitalization pulpotomy. So nobody does that unless until you are dealing with a probably a medically compromised patient. That's the only reason you would go for a double sitting pulpotomy. Now, if you are placing a pulpec, you are making sure that your uh, pulp becomes non-vital. So if your pulp is becoming non-vital, what is the point of doing the pulpotomy? You are no longer maintaining the radicular vitality. You are completely devitalizing the pulp.
There is another question. Is it okay to use formic
They
nasal
mean
despite
pulpotech as.
Yeah.
Okay, Dr. Nasha, can you repeat the question again, please?
Is it okay to use formic nasal despite its high toxicity?
Yes, it is okay to use formicrosol. A lot of us feel that formicrosol is cytogenic, mutagenic, cytotoxic, and but there are studies which were done by Ranley and Garcegoda. They evaluated that you would have to do nearly 400 pulpotomies in a patient, in one single patient, for that effect to actually happen with full concentration. And what we use formicrosol, we use
Yeah,
1/5 dilation. So 1/5 dilation
diluted
in
form.
maybe all the teeth also would absolutely not matter. And we are not pouring the
Yeah,
formicrosol actually inside the
good
teeth.
news.
We are, we are damping on a cotton
Yeah,
and then
yeah,
again damping it and then placing it. So it's the
yes,
dilution actually becomes
yeah.
maybe 1/50th. So I don't think so it's going to cause anything. Actually, it's not I don't think so. It's been proven that it doesn't cause.
So these are good news, Dr. Marwa. These are good news
Yeah.
for us, for
And
Egyptians, because we are
if you
using it.
use if you use ferric sulfate, it's good enough. It's the same thing. It's the same
Yeah,
thing as formicrosol, and equally, cost effective. And I'm using
yeah,
formicrosol.
for
It's been
omeprazole.
15
Yeah,
years now. I'm using formicrosol
yeah,
for primary
as
teeth.
here.
For
Yeah,
primary teeth. Never for young permanent teeth
for
or
primary teeth,
permanent
of
teeth, but
course.
primary only.
No, no, no. Yes, for primary teeth. Any other questions, Dr. Nashwa?
No, there is no other question. Thank you, Dr. Marwa. Okay. Thank you, Dr. Afir.
Perfect.
Thank you very much. Thank you, Dr. Nashwa. Thank you very much, Dr. Marwa. Actually, we are pleased and enjoyed your lecture and your nice presentation and your speed of talking. It's very nice. And hopefully to meet again, but face to face here in Egypt after, or in India, by the way, in India, but after
Either way.
ending the, yes, hopefully, but after ending, inshallah, the crisis or the pandemic of COVID-19, and wish you all the safe time and to see you again, inshallah. Thank you very much.
Thank you. Good day.
Thank you.
Bye.
Bye bye.